didn't realize. So welcome, clinical problem solvers. Great to be back after a little break for the holidays. And if you celebrate Christmas, I hope you had an amazing weekend with your family. So today we are here for Endocrinology VMR with the one and only Thiago, who is kind of the endo expert of the team and also an amazing leader for the VMR team. So really excited to hear him discuss, and Kanu, who is also a regular on VMR and a great discussion always, is presenting a case today. So maybe Thiago, you can introduce yourself, even though I think you need no introduction.
Thank you for your kind words, Valeria. So I am Thiago, I'm from Brazil. I'm an endocrinologist here. So English is also a work in progress. So please let me know if you don't understand what I say. And I'm looking forward to learning from Kanu today because it looks like he has a case. So if you want to introduce yourself, Kanu, go ahead.
Hi, thank you, everyone. Thank you, Will, for the kind introduction. I'm Kanu. I'm an internal medicine intern right now. And endocrinology is one of my favorite specialties. I always like to discuss endocrinology cases. So happy to learn something from Thiago and everyone.
Whenever you're ready, Kanu.
All righty. So.
Sorry, can you see the screen or not yet? Yes, okay, perfect. Sorry, thank you.
Okay, so chief concern, 26-year-old male with pain in bilateral lower limbs. History and physical. So history, he was apparently normal about 2 years ago when he developed insidious onset pain in bilateral lower limbs. He started developing pain in the knees, and then it gradually spread, involving the whole limbs. The pain improved on taking analgesics, and he also started complaining of decreased power on the right lower limb while performing his routine work. Of note, after about 4 months of this onset, he had a fall in his house and he was admitted to the hospital having fracture of trochanter of his left lower limb. He underwent surgery for the same, and his post-operative course was otherwise uneventful. And he was discharged on calcium and vitamin D, 60,000 international units once a week. When he came out, his histopathology from the operation showed features of Paget's disease, and that's why he was referred to us for management. He otherwise didn't complain of any abdominal pain, no burning micturition, or any increase in the frequency of micturition. No history of any mood disturbances, no history of seizures, vomiting, headache, blurry vision. He never reported any previous fractures or anything like that in the past.
So Thiago, as an endocrinologist, how would you approach such information?
So that's a very interesting case. And I think there is a key message here. You know, when can we start it? Like, oh, he has pain in his lower limbs. So many things can be the reason for this pain. But then we have a very important thing that happened, a fall and a fracture. So this is completely not expected. We don't expect people to have a fracture after a low energy trauma. So when you fall from your height, then you are not expected to fracture. Maybe you can have a fracture on your wrist, depending on how you fall, but you should not fracture your trochanter. It's a very large bone, and you should expect it if you have like bone problems like osteoporosis, and especially in women who are over 65 years old, and also after a high energy trauma, like a car accident or things like that. But for a 26-year-old to have fractured his greater trochanter after a fracture, there is a disease. There is no way it's normal. It can't be normal at all. It's not a simple fracture. And I think that's the big point to keep in mind here. If you see someone having a fracture after falling from their height, a low energy trauma, then you should be suspicious there is something going on in the bone metabolism. And I think that's what we have, and we will discuss and learn from Kanu over the case. Paget's disease is another thing here. And Paget's disease, I think I tweeted about it months ago, because there are many diseases with this name. But for bone, it expected in people, in elderly people, not 26-year-olds. So I would like to know a little bit more about this Paget's disease diagnosis, because again, it would not be expected at this age. Generally, they have pain, and alk-phos is very high. So this is the way that Paget's disease of the bone is diagnosed, but not at this age. So when I see like Paget's disease of bone, again, because there are many Paget's disease at this age, I just ask myself, is it correct? How was it diagnosed? And why is it going on? And for sure, we need further history, personal history, and family history as well. And for personal history, I would say when you see a fracture that is not expected, as this one in a 26-year-old male, low energy trauma, then for the medication, it's very important to know about corticosteroids exposure, because there are many diseases that are treated with corticosteroids, and they are a problem to the bone. And there are many risk factors for bone fracture, like tobacco, alcohol, low testosterone, corticosteroids. But as I said, that's an important thing to keep in mind. If you have chronic exposure to corticosteroids, it's a big and important cause of fracture. I'm just taking a look now at the chat, because I was not following the chat, and I would know if someone has something to add. I see that Travis is just describing Paget's disease of the bone, and it's not common. Dr. Center is talking about hypocalcemia, and you know, prescribing calcium for hypocalcemia is something that I've seen, and that I mean, it's not something you should do at first, because hypocalcemia is not common. If you do not ingest calcium, then you probably won't have hypocalcemia. You will have like high PTH, but for you to have hypocalcemia, it's very rare, because the blood calcium is very well regulated. And if you don't have a sufficient ingestion, then you will take the calcium out of the bone, and it goes to the blood, and then it will be normal in the blood. So I think that's another important thing to discuss. If you see hypocalcemia, try not, it's imperative to understand why it's happening, because probably there is a subjacent disease. They are, I see, same as saying here, talking here about hyperparathyroidism, which is a risk factor for bone disease. So hyperparathyroidism, the PTH is high in the primary hyperparathyroidism, especially PTH is high, calcium is high, and then this PTH is activating osteoclasts. But, you know, even in the secondary hyperparathyroidism, you will have bone problems, but it's more complex. Like if you have renal insufficiency, there are many factors playing to have a bone damage and then bone fracture. But again, it's all important to keep in mind corticosteroids exposure, renal insufficiency, family history, personal history. Yes, Dr. Center, if you want to talk more about CKD, but yeah, hypocalcemia can develop because, you know, in CKD, you have low PTA, you have low calcitriol, because, you know, the hydroxylation of vitamin D is a problem, because the first one in the position 25, it happens in the liver, the second one in the kidney in the position 1, and then you have the active vitamin D, it relies on the kidney. So when you have low calcitriol due to CKD, you have hypocalcemia, and then the CKD, you also have hyperphosphatemia, which is another factor to have hypocalcemia in CKD, low calcitriol and high phosphorus. You know, many things here we're just saying because by now I would like to know more about the history, and then we will need labs to progress on the hypothesis, but just to keep in mind that there are many possibilities here.
Sure. Thank you, Travis. So thank you, Thiago. And the past medical history, he doesn't have any past medical history. Social wise, no alcohol, smoking, or IV drug use. Travel history, no recent history of any travels. Of note, patient demographically belongs to India. Medication wise, only medications were the calcium and vitamin D, 60,000 units after the surgery that he got for about 2 months before he presented to us. Allergies, he didn't complain of any allergies. Family history. So I took a 3-generation family history on him, and he didn't have any history of any previous fractures or any history of recurrent fractures in the family. No history of pancreatic cancers or any manual-related syndromes in the family either. Examination. So vitals wise, he was afebrile. Pulse rate was 72. Blood pressure was 116/58. His respiratory rate was 14, saturating 98% on room air. He was otherwise alert oriented ×3. He didn't have any pallor, icterus, cyanosis, clubbing, no lymphadenopathy. Cardiovascular was normal, respiratory was normal. Moving on to his extremity exams. So he had a left limb which was swollen, externally rotated with apparent shortening just after the surgery. He also had kyphoscoliosis with no vertebral tenderness. He otherwise had short stature with a Z-score compared to the median for that age. And his neck examination showed a 3 by 3 centimeter swelling on the anterior aspect of the right side of neck, which moved with swallowing, didn't move with protrusion of the tongue, and didn't have any visible pulsations and no scar, sinuses, or fistula. The same findings were confirmed on the palpation. Do you want me to go through the labs too, or you want to stop here?
I think we can stop here.
Okay.
And please, I was just following the chat. Please let me know if there's something else to discuss. But you know, when you just because you describe it, what's different here is the neck, this mass, which I don't know what it is, but just it is important that it does not move with tongue, because for this mass, you know, the thyroglossal duct cyst, it can persist throughout the life of the person, and then it can be a possibility of having a mass in the neck, but it doesn't look like it is the case here. I would like to take a better look at this mass, and given his history, I would say that we should start from bone, we need the general lab because we were discussing like CKD and all of those issues, but also we need the phosphorus, we need calcium, we need magnesium, we need maybe PT8 and vitamin D. I say maybe because in the past it was discussed like, oh, primary hyperparathyroidism, you will have hypercalcemia. And actually it's the most common cause of hypercalcemia. The most common cause is primary hyperpara, but also you can have normal calcemic hyperparathyroidism. So for this reason, I'm saying that you should start with PT8 as well, because even if it's normal, the PT8, it is, even if the calcium is normal, it is possible to have a primary hyperparathyroidism. Just to start with this labs, because we don't have any clues. I'm just reading the pseudohypopara, which is a rare disease. It's good to think about rare diseases. Often you will have a familial history, but sometimes you don't have familial history, and it is pseudohypopara, but we will need we will need labs. And as I said, it's important: calcium, phosphorus, vitamin D, magnesium, PT8, and urinary calcium as well. I mean, it's arguable not to start with urinary calcium, but likely it will be needed. And I think that's it by now. If there's something else, please just let me know that you want to discuss or to add, people who are in the chat, because when I'm talking, it's difficult to follow the chat.
So Thiago, I have a question. When you're dealing with a new patient with a cervical mass, how you as an endocrinologist approach such complaint? Oh, you're muted.
So cervical mass, if you are thinking in endocrine problems, you are thinking thyroid, right? Because for cervical masses, it can be lymph nodes, muscle, thyroid, and even the trachea, esophagus. But if you think about thyroid, then you want to know how is this mass, because it's huge, 3 by 3 centimeters. You want to know the features of this mass. If it's hypoechoic, hyperechoic, if it's fluid, if it's solid. So you will need ultrasonography. If it is thyroid, I'm just saying, if it's thyroid, you will need ultrasonography to take a deep look, because if you have a 3 by 3 centimeters mass in the thyroid and it is solid, it will require biopsy, FNA. If it's liquid, if it's a cyst, then you don't need biopsy because of the size, it's huge. But if it's liquid, it will change the management. So for a mass, if it's thyroid, you need ultrasonography, and also you will need TSH, because if you have a mass and you have also hyperthyroidism, and this mass is proven to be the reason for the hyperthyroidism, then you don't need biopsy as well. So for a mass in the thyroid, you will need ultrasonography and TSH, both, to get the features of the mass and also to understand if it's producing hormones. And it's very interesting because, if you have a mass that is producing hormones in the adrenal, it can be malignant. You can have like a Cushing syndrome from a cancer, from adrenal cancer, but that's not the case for thyroid. So if you have a mass and this mass in the thyroid is producing hormone, then it's benign. So that's very interesting. When you depend on where it is, it changes the management. And for thyroid specifically, if you have something in your thyroid and it's producing hormones, then it's benign. Another interesting thing is that hyperthyroidism or thyrotoxicosis, it causes bone damage. It causes bone loss. It causes osteoporosis. For this case, I don't think a lot about it because thyrotoxicosis cause many symptoms, and he's young. But just for you to know that if you have like subclinical hyperthyroidism for decades, then you can have secondary osteoporosis. I think it's an important thing. But here, we need to understand better this mass in his neck for sure. But I can't see at this moment a specific link between the mass and the problem he has by now, again, because as I said, we need labs. You know, in endocrine diseases, we always need labs. And when there is a fracture at this age, it's very unlikely for you to solve the case without labs.
Thank you, Thiago. This one has a lot of information. So I have 3 sets of labs just to show the trend of the labs. So the first labs were done when he first had a fracture. So that at that time, hemoglobin was 10.4, white count was 5,200, platelet count was 202, ESR was 68, CRP was 36.9, his procalcitonin was normal, calcium was, this is ionized calcium, which was 2.16, which is very high. Normal limit is 1.1 to 1.3. Albumin is 3.4. Alkaline phosphatase was 1585.
Can you go a little slower?
Sure.
For us?
Let me see if I can. Calcium was 2.16. Albumin was 3.4. Alkaline phosphatase was 1585. And vitamin D was 22.7. A PTH was done, which was 839. Normal is 15 to 65. And then once he presented to us, at that time, hemoglobin was 7.2. White count was, let me paste this out for you. White count was 7,700. Platelet was 286. He had normal differential. BUN was 33. Creatinine was 2.05. His eGFR was 43. Sodium 140. Potassium 3.4. Calcium 18.2 milligram per deciliter, and ionized calcium 2.04. His phos was 3.3. Alkaline phosphatase was 342. His total protein was 6.3. Albumin was 3.4. Globulin 2.9. Total cholesterol 116. LDL was 48. HDL was 33. Triglyceride was 171. We also got a UA, showed 8 to 10 RBCs, 10 to 12 white cells with no proteins, ketones, or glucose. His CRP was 4.9, normal was less than 0.5. His B12 level was 519 and folate was 13.2. We also got an iron panel, which showed iron deficiency, iron 35, transferrin 185, ferritin 261, and TIBC 48. You also wanted urine calcium and creatinine. So the ratio was more than 0.01. His urine calcium was 14.44, and multiple myeloma screen was negative, including SPEP, UPEP, and fixation. This was the hormonal profile that we did. His TSH was 3.05, T3 was 0.99, T4 was 3.45, IGF-1 was 186. Again, his IPTH we did, which was 2,600. Vitamin D level was 39, cortisol was 18, and prolactin was 30. For the convenience, I put everything in the chat.
Thank you, Kano. That's very, very interesting. And, you know, just to interact more with you, there is a diagnosis here. And please, I would like you to type the diagnosis if you know, because with this panel, there is a diagnosis. And it's very important to learn it if you don't know about it yet. With these exams, there is just one possibility. I mean, there are more things that can be happening, but we know that there is something very important happening with his hormones. and probably link it to his fracture.
Yeah, but
if anyone wants to talk about it or to type it, please go ahead.
Meanwhile, I was thinking I could also show you the skeletal survey that we did. That would probably show a lot more information. So I'll share the screen. So I hope everyone can see it. So this was the ultrasound that we did, which showed some hyperechoic stones in the kidney, both the right and the left kidney on the bottom. And after that, we got a skeletal X-ray done. This is the olecranon. They were clear, but there was definite subperiosteal resorption in all the bones, especially in the fingers. If you see, the fingers are tapered off, and he has evidence of distal acrosteolysis. And there are some lucences in his metacarpals, which is very interesting. And then again, he had multiple lucences and areas of subperiosteal resorption. This again, I'm not sure if you're able to see it clearly. This area in the distal tibia was kind of a lucent. We felt it was lucency, but then it was found out to be a ground tumor. Again, kyphoscoliosis, and there are some radiopacities in the lower abdomen consistent with his kidney stones. And as you can see, clavicle, scapula, everywhere there are lytic lesions and areas of resorption. This is the Rutger spine, Rutger-Jersey spine that we see. This was his fracture site initially, which was like that. And again, there are areas of multiple subperiosteal resorption. And this is a salt and pepper skull with areas of resorption, as well as superadded some calcification. That was a initial imaging that we did.
That's great, Kano. That's beautiful from the medical standpoint. And I think that the takeaway here, something that you should know, is that once you see hypercalcemia, the next thing to do is to measure PTH always. And if you have hypercalcemia and then you have high PTH, you have a diagnosis. It's primary hyperparathyroidism. So if you have a low ingestion of calcium, if you have CKD, if you have a reason to have a low calcium, PTH will raise and you have high PTH, but calcium will not be high. There is no supercompensation. There is no way it's going to happen. So every time you see a high PTH and a high calcium, you have a disease in the parathyroids. There is no other way it would happen. So once Kanu showed this hypercalcemia and then this huge PTH, it's primary hyperpara. Interesting things. PTH is high after fracture. It's physiology. You should expect PTH to be high after a fracture, but you should not expect calcium to be high after a fracture, and you should not expect PTH to be at this high. ALK-Phos is just a marker of bone formation. So if you have a fracture, ALK-Phos will be high. If you have a primary hyperpara, you have a high PTH, you have a high calcium, and this high PTH will activate osteoclasts, but you know the turnover of the bone increases. And as the turnover increases, ALK-Phos increases as well. So ALK-Phos is very non-specific, and it's a marker of bone formation. He's losing bone more than forming bone, for sure. He had a fracture, an important fracture, an unexpected fracture, but ALK-Phos is high and it's expected to be high. So multiple myeloma, you can have hypercalcemia. Actually, it's very expected for you to have hypercalcemia due to multiple myeloma, but how would be PTH? The problem with multiple myeloma is not in the parathyroids. So the parathyroids would sense the hypercalcemia, and then the PTH would be low. So that for multiple myeloma. And other causes of hypercalcemia. If you have hypercalcemia and your parathyroids are working, they will sense this hypercalcemia and PTH will be low. That's the reason that I said, if you have high PTH and high calcium, you have the diagnosis no matter what, no matter the rest. It's primary hyperpara. And then Rafa, now we know this mass in his cervical mass. Now it makes sense. It should be parathyroid. So I think Rafa said that in endocrine, we use the biochemistry, and then the image. Because, you know, the diagnosis, it's biochemical. So how do we diagnose this primary hyperpara? Hypercalcemia and high PTH. Now we have to localize the problem. Where is the problem? Because we have 4 parathyroids. They are posterior to the thyroid. So most commonly we have adenomas. So only one gland has a lesion, and then you resect the lesion, and then the problem is solved. But you can have hyperplasia. So all glands can be affected. And it's common when you have MEN1, multiple endocrine neoplasia type 1, 3 Ps, parathyroid, pancreas, and pituitary. So when you have these 3 organs affected, and the most common organ affected is parathyroid in MEN1. So when you have MEN1, hyperplasia is more common than an adenoma affecting just one gland. So now we need to localize what's going on. Is just one gland affected or more than one gland affected? But just before that, we just localize which gland or glands are affected if we will indicate surgery. So when do you indicate surgery in primary hyperpara? Always? No, not always. There are 4 indications. Age less than 50 years old, which is his case. Calcium more than 1 milligram per deciliter above the upper normal limit, which is his case as well. And just 1 is indication, but he has, you know, all indications. The 31 is bone lesion. So if you have like secondary osteoporosis, and he had a fracture, a fragility fracture, so he has this indication as well. And the 4th is nephrolithiasis, nephrocalcinosis, or urinary calcium urinary excretion that is very high, above 200, 400 plus other risk factors for nephrolithiasis. So the indications for surgery are based on the level of calcium, or the age, or the renal system being affected, or the bone system being affected. If you have one of those indications, then surgery should be done. And so he has all the 4. So here we want to localize the gland, and we can do it by ultrasound. We can do it by MRI and also scintigraphy. Scintigraphy is very interesting. Scintigraphy you can use for bone, you can use for heart, you can use for thyroid, you can use for parathyroid. And how do I explain scintigraphy? So ultrasound, MRI, CT, it's an anatomical map. So if you have an MRI of your parathyroids, you have the map of your parathyroids. Ultrasound, same. Scintigraphy is the functional map. You see where it's functioning, and it works for your heart, it works for your kidney, it works for your bone. Whatever scintigraphy you do, you will be seeing the function of the organ. So we need to localize, as I said, so he goes to the surgery, and we should think that, oh, he has a very severe hyperpara. So I'm worried about a cancer. Cancer is not common at all for parathyroids, but I'm worried in his case because he's very young, has a severe hypercalcemia. And also we should think about MEN1. MEN1 is autosomic, it's dominant. So often you have families affected, but I would like to know more about it as well. Also regarding his anemia, I have no idea what's going on here. So I'm just taking a look right now that the iron is low, but ferritin is not low. It doesn't look like the classic iron deficiency anemia, but it maybe it is the case, because, you know, we can't like try to couple the iron deficiency anemia with some pancreas tumors, but it doesn't look like. But for sure, we need to better understand what's going on with his blood, because it's also completely unexpected to have a hemoglobin of 7.2. So I'm also curious about the reason for him to have this anemia, and how is it related to the rest of the case.
So Thiago, as you wanted a system EV scan, so we did that. We also did an ultrasound. So the bedside ultrasound we did showed, you know, a parathyroid lesion in the right inferior area. And we confirmed it on the system EV scan that there was an increased tracer uptake in the lower half of right lobe of thyroid, which also persisted on a delayed 50-minute image. There was also multiple foci of tracer uptake in bilateral shoulder and bilateral ribs. Apart from that, we also did a 4D CT scan just for localization, because we felt the patient anyways needed the surgery. So it showed areas of calcification with necrosis and no enhancement on the arterial phase. The lesion was about 2.3 by 3 centimeters on the 4D CT scan. Anatomy was clear, no invasion of thyroid was seen. Diffuse osteopenia with avid brown tumors in right parietal bone, left frontal bone, mandible, C6 vertebra, clavicle, scapulae, humeri, sternum, ribs. So he had very diffuse skeletal involvement otherwise. So after that, he was scheduled for a surgery. Any hints or any guesses on what the final diagnosis turned out to be?
I just want to comment that the system EB scan, so it's the scintigraphy that I was talking about, as Kanu said. So it's the radio marker for parathyroid. So for parathyroid, the scintigraphy is done with system EB. And so, you know, so here, just one gland is affected based on image, which is typical for primary hyperpara. And having a normal prolactin, I don't know if MRI of the pituitary was done, but having a normal prolactin, a normal G8 and IGF-1, with just one gland of the parathyroid affected, MAN1 is unlikely. So let me be clear. For MAN1, generally mostly there is more than one gland affected, more than one parathyroid affected, and here there's just one, so it goes against MAN1. Also, a normal prolactin, normal IGF-1 goes against, because for pituitary tumors, the most common are the non-functioning, then prolactinoma, and then IGF-1 producing tumors, G8 producing tumors, sorry. So here it looks like it's not MAN1, and no family history, so it's not MAN1. So here, the pathologist will be responsible to tell us if it is an adenoma, which is much more common. Over 95% of the primary hyperpara, they are caused by an adenoma or a cancer. And I would say always I see a primary hyperpara, I'm not worried about cancer. But in this case, I am. Why? Because of the severity. So for primary hyperpara, so for parathyroid carcinomas, adenocarcinomas, the primary hyperpara is very severe. And that's, again, I was just saying that for thyroid, if you have a tumor and it's producing hormones, it's benign. For adrenal, it may not be benign. And for parathyroid, it's the same. So most tumors, most parathyroid tumors, they are benign, but they may be malignant. And the higher the calcium, the higher the chance of malignancy. which is interesting for parathyroid. So, and that's something that I'm worried. And for the brown tumors as well, there are many brown tumors, so many, you know, the severity is so intense that you have nephrolithiasis, and also you have, as Kanu showed, the bone is being affected everywhere. So PTH is high, activating osteoclasts, and bone is just, the bone turnover is so high that you see those tumors. It's called brown tumor. It's a finding that you just see in severe cases when you have primary hyperpara and it's severe. So I think that Dr. Center was spot on, and here that we have to wait to see if it's an adenoma or cancer. As I said, adenoma is much more common, but in this case, I don't know. And Paget is not the case here at all. So he doesn't have Paget. And, you know, there is nothing here that is a fit for Paget's disease of the bone. You know, you have high alk phos, but just keep it in mind. I think that the boards, I've just done step 3, and I know that in the boards, you kind of keep in mind that if you have a high alk phos, then think about Paget's disease of the bone. But, you know, for the life, it doesn't make sense. It's very non-specific, and you should think in Paget's disease in the elderly, and they are asymptomatic, or they have bone pain and just a mild elevated alk phos, but alk phos is high whenever there is bone formation. And I'm looking forward to know what's going on.
You're spot on, Thiago. So first of all, regarding the Paget's disease diagnosis, so we also asked our pathologist to take a look at that bone biopsy, and it was actually a brown tumor. But because of the lamellar formation, the other pathologists probably thought it was Paget's. They didn't do a PTH level at that time, so they were not sure. Because we did it, we had a little bit of bias towards a brown tumor, and we found some RBCs as well in that specimen. And regarding the parathyroid specimen, so we resected it grossly. We also did a partial hemithyroidectomy because we were suspicious of cancer, especially with this large size. And because it's a palpable lump, if we suspect there's a parathyroid lesion and it's palpable, it is cancer until proven otherwise. So we resected his thyroid. So thyroid specimen was clean from parathyroid perspective. And the official biopsy report was a solid cystic lesion with focal areas of hemorrhage with enlarged hypercellular parathyroid gland composed of chief cells arranged in nodules. There was vascular invasion noted in multiple sections, but no capsular invasion otherwise. The immunohistochemistry was positive for cyclin D1. And the hemithyroidectomy specimen didn't have any evidence of parathyroid tissue or invasion. So the diagnosis was ultimately right inferior parathyroid cancer.
That's a great case. I mean, it's very impressive how we could, you know, think about it. And it's rare. It's really rare. I mean, it's not so bad because the survival, I don't know how he is, and I would like to know, but the survival for parathyroid cancer is not bad. It's over 80%, 80%. So most patients who have parathyroid cancer, they will not die from this cancer. It's very, very unusual. I think that the last time I saw parathyroid cancer, I was a fellow, because, you know, in clinical practice, it's far from being common. So thank you very much for sharing this case. And, you know, I hope you could understand how to work this case, and how, you know, in endocrine, we have like tiers in our mind, and we go tier by tier. So once you have hypercalcemia and high PTH, then you have a diagnosis, then you should look what's going on, and then you go to the image. And, you know, it's always this way, as Rafa said, biochemical, then image, and then look what's going on. And I'm looking forward to learn how he is, and also for our teaching points.
Yeah, so when he first came, the calcium was like 20. So we were already scared on how we're going to manage that calcium. So we gave him a lot of fluids. We gave him bisphosphonates every day. We gave IV calcitonin. And after like 6 days, it finally came down to 11 or 12 so that we could operate upon him. And post-operatively, his ionized calcium just during the operation, his PTH dropped down by 93%. By Miami criteria, that's a successful parathyroidectomy. And we also did a localized radio tracer study during intraoperatively to find out if there's any other parathyroid lesion just in case, but there wasn't. After that, because he had such high PTH levels preoperatively, so he developed hungry bone syndrome after the diagnosis, after the surgery, and it was very hard, but he's finally, he's still recovering from the surgery. He's still in the rehab last I checked upon him, but otherwise he's doing well. He's otherwise able to do his activities of daily living with no issues. And on follow-ups, his labs have been normal except for elevated alkaline phosphatase, which is acceptable because the bone is still regenerating.
Yeah, so just because I'm reading the chat, yes, the post-op is very complex. Most patients, they have hypocalcemia because you are just taking out the PTH and all, you know, one gland is out, you have 3 glands, but they are not producing PTH because they are working. If they are normal, if they are healthy, they are understanding that the PTH is high, so it's very low. So for primary hyperpara, 10% of patients, and I'm just talking about the usual adenoma, 10% of patients, they have hypocalcemia. So it's very important to have a normal vitamin D and to monitor calcium. Most patients require calcium after surgery for a while. Some of them, they require calcitriol. And hungry bone syndrome, it is expected in this case because you have brown tumors and it's severe. So hungry bone syndrome is unusual after parathyroidectomy, but in this case, it is expected because, you know, the PTH is affecting a lot the bone. So he had a fracture, he has many brown tumors. So once you don't have this high PTH, it's like bone is just wanting calcium because the calcium was high in the blood because it was being taken out of the bone. So it was going from the bone to the blood. And now you don't have this high PTH, and then the calcium, it goes to the bone. The bone is just willing to have calcium and calcium and calcium, and also phosphorus. So that's the way we diagnose hungry bone syndrome, because both calcium and phosphorus, they go down. Yeah, because if it was just hypoparathyroidism after the surgery, phosphorus would be high. So after primary hyperpara surgery, you should have like low calcium. It's very common, but phosphorus is high because PTH is low after the surgery. And in the hungry bone syndrome, both are low. So you should just give the patient calcium and phosphorus and also calcitriol. And just to give you a brief review on hungry bone syndrome, after parathyroidectomy, and both calcium and phosphorus are low. That's the way we diagnose it. And I think I just talked a lot. Rafa, just let us know what you do now.
Oh, thank you so much, Thiago. Maybe we can go to Valeria.
Yeah, this was an amazing case. Thank you so much, Kanu and Thiago, and also for describing Travis and Prakit, that is no longer with us in the call, but did an amazing job keeping up with all the information. So on the teaching points, we started with the case of a young person with a fracture after a fall, which is not something we should expect. And Thiago shared with us 2 scenarios in which we should expect a fracture after a fall, which is someone who has a great age, for example, postmenopausal women who have osteoporosis, and also from a great height, which was not the case today. And so risk factors for fractures in a young person include tobacco, alcohol, low testosterone, chronic use of corticosteroids, and secondary hyperparathyroidism, because primary usually causes hypercalcemia. And so then something on the chat that came up quite early on was the possibility of Paget's disease of the bone, because we also have Paget's disease of the breast. which is an accelerated bone remodeling process that results in bone overgrowth, like a rebound from all the remodeling. But in this case, it will be rare because the age of onset of pages is usually from 55 years on. And so this was quite a young patient. And most people are asymptomatic, but the most common symptoms are pain and skeletal deformities, which is a fact that I got from actually one of the tweets that Thiago made about Paget's disease. And lab findings in this disease include an elevated alphos, abnormal calcium and phosphate, and hyperuricemia from the bone turnover. And then in the physical exam, we found that the patient had a cervical mass, which was not mobile with deglution or with movement of the tongue, which is great because that could like sign a thyroglossal or a persistent thyroglossal duct. And so Thiago shared that with us his approach to a cervical mass as an endocrinologist. Of course, the first thing is the thyroid, and the possibility of a thyroid mass is a must to ask for an ultrasound and a TSH to see what is the density of the mass and if it's a functional mass or not. And so if it's a solid mass, we will go for a biopsy. And I'm not sure, I have to hear again this VMR to see what was the indication of liquid mass. But then if it's a functional mass, it is a good sign because most likely it is a benign mass. And then we saw the patient with the labs had hypercalcemia. And so the next step for that, and the CP over schema is great, is to check PTH. And so we have PTH dependent causes and PTH independent causes. And in this case, the patient had an elevated PTH, which suggests primary hyperparathyroidism as the most likely cause. And even though PTH can be elevated after a fracture, it's not expected to be elevated. The serum calcium is not expected to be elevated. And so this was what made it a very striking finding. And then also the images that Kanu shared with us showed a salt and pepper pattern on the skull, which is something that can be found in hyperparathyroidism. And then also with this diagnosis, Thiago shared with us indications for surgery, which include age younger than 50 years and serum calcium graded 1 milligram per deciliter above the upper limit of normal, fractures like we saw in this patient, and also the presence of renal calculi as the patient also had. So it was a really great case. Thank you so much, and see you all tomorrow.
Bye.